finally we get to our, renin-angiotensin-aldosterone system, right? You know what? I'm gonna draw this out by hand because like I feel like these diagrams sometimes they make these algorithms, they become super confusing. So let me draw this out, and then we'll go through the diagrams. So, and then if you have any questions midway through, you could always stop me, ask me, right? So we're gonna say we're gonna draw the circulatory system first. So what I'm gonna do is I'm gonna draw your right heart, right? And we're gonna say this is your right heart. This obviously is gonna be your superior vena cava. This is gonna be your inferior vena cava. Here we're gonna get a capillary network going. And then it's gonna feed into your arterial circulation, right? So you have your arterioles. And then what we're gonna do is this is gonna be your left heart. And then this is gonna come here. And then here we have your pulmonary circulation. I'm gonna do the pulmonary circulation here. Right, your pulmonary capillaries. And certainly, right, we have your lungs, which we need to draw. So we're gonna say, I'm gonna draw one lung, but you guys know, right, we have two lungs. And then here, we're gonna do some alveoli. Right. So we have the lungs. So what else do we need? We need the kidney, right? The kidney was our important thing here. So from the kidney, we said from the arterial network, right? We have blood that's coming to the kidney. And then here I'm gonna draw a little nephron here, make it a little bigger. So this would be your nephron. This is going to be the Bowman's capsule. This is going to be your thin descending loop of Henle, right? And this is going to be your thin ascending loop of Henle. We're going to do the thick ascending loop of Henle. Then we're going to do the distal convoluted tubule and collecting duct. Then eventually we're going to say urine is going to come out of here. It's going to be urine. This is the collecting duct. And then from here, right, this was your afferent arteriole. It's going to go into the Bowman's capsule. It's going to come out as the efferent arteriole. And then it's going to feed back into the circulation, right, with the renal vein, switch to blue, right? And then it goes back into your inferior vena cava, right? We're also going to need, right, we also need the adrenal cortex. So I'll draw the adrenal cortex on the side here. And we're also going to need the liver. Liver is very important. We're going to secrete something. Draw liver here. Actually, let me take a different color. Make liver in here. All right. So far, I think might be self-explanatory. Okay, let me make sure you guys understand this is the kidney. Okay, so far everybody's with me? Yes, no?
Yep.
All right. So let's talk about the Renin-Angiotensin-Aldosterone System, and I'm going to give you the basic physiology, what happens normally, and then we're going to talk about what happens, right, if long term, what are the problems long term, and so forth. So let's just say, right, you have a guy, right, who was minding his own business, and then some guys came up to him and they wanted his wallet, right? And the guy said, "I'm not going to give you my wallet," and so they stabbed him, right? So he got stabbed and he is hemorrhaging. So we're going to say he got stabbed here and he's losing blood, right? Let's just say, so far there's no EMS response yet, right? The guy's losing blood. Now, we talked about, right, your normal cardiac output is about 5 liters, right? And that's every minute. And this blood is coming to your kidneys. About 20%, we said, about 1 liter is going to your kidneys. Now, as you guys are aware, right, if somebody got stabbed and you're losing blood, right, do you think your blood pressure, right, if this is going on, your blood pressure is going to go up or your blood pressure is going to go down as the time goes by?
It's eventually going to drop.
Yeah, so eventually your blood pressure is going to drop. So far, everybody's with me, right? So as time goes by, as you hemorrhaging the blood out, right, your blood pressure is going to start to decrease. And then if your blood pressure is decreasing and you're hemorrhaging, there's less flow of blood to your kidneys, right? There's less blood coming to your nephron. Why? Because A, you are losing blood, right? And 2, your blood pressure is decreasing. Now, when this is occurring, right, there is special cells on your kidneys, right? I'm going to draw them here on your nephron. So first of all, there is cells are found on this distal convoluted tubule, right? These cells are called macula densa. And there's these cells that are connected to the efferent arteriole. And they're also connected to the macula densa. These are called Pulmonary cells. So it's not so much for you to remember the names of this, but these Pulmonary cells, they are like the baroreceptors. They are pressure sensors. And what this macula densa cells is, they are chemoreceptors, right? So these cells, the Pulmonary cells, they're always looking at pressure. And these cells at the macula densa, they're looking at, as a chemoreceptor, specifically, they're looking at the sodium amount, right? So think about this, right? As the blood pressure is decreasing, less blood flow, right? These cells sense there's a drop in blood pressure, right? And the moment these cells sense there's a drop in the blood pressure, these cells are going to start secreting a substance called renin, which is an enzyme, into the circulation, right? Also, if your blood pressure is low, right, and you have less blood flow, right, do you think if I have less blood coming in, the blood flow through this is going to be fast or slow through your nephron?
It's going to be slower.
Right? Andrew, I think your mic is on, right?
It's not me.
No, I got it. It's Andrew. So the blood flow through this is going to be lower. So let me take a red color. So blood flow is going to be lower. So what's going to happen is, because the blood flow is low, right, the reabsorption of these solutes that's coming into the blood is going to be faster, because if the blood flow is slow, right, then the kidney's nephron and all these cells that are found on the nephron, right, they're able to extract all these cations much quicker because the blood flow is so slow. So as the blood is coming to this portion of the nephron, especially to the macula densa, if all these cells extracted all the sodium, there's going to be a low amount of sodium. And this low amount of sodium that's now reaching, right, these macula densa cells, they're also going to secrete renin into the bloodstream together, right? Together, these Pulmonary cells and this Angiotensin cells given a very special name. So I'm going to draw it like this. So combine this Pulmonary cells and Angiotensin cells. They're known as Juxtaglomerular Operators, right? So Juxtaglomerular Operators are a combination of the Pulmonary cells, which are pressure measuring device, and Angiotensin, which is a chemo measuring device, right? And they're constantly monitoring the flow of blood through your kidneys, right? So because there's low blood flow, because there's low blood pressure, both of these cells, right, are sending renin into the circulation. So the renin is now coming into your efferent arteriole, then it's coming into your renal vein, and all of a sudden, this renin is going to end up in your circulation, right? Does this renin do anything right now? Or not?
Not until it converts to angiotensin 1.
Yeah, it will convert. But for now, we're going to say it doesn't do anything because right now, right, it's just found its way into the blood. It's an enzyme, right? It's only secreted, what I want to point out, it's only secreted when these cells, these juxtaglomerular operators are sensing, right, that there is low blood flow and low blood pressure in your, right, in your kidneys, in your nephron. But liver plays a major role, right? Liver makes a special kind of protein that it secretes. This protein is called Angiotensinogen. And you notice the ending of it is GEN, right? GEN. So this form is inactive, right? Angiotensinogen is inactive. They call all of these inactive proteins, right, the precursors, they call them zymogens. Right? You may have heard of like pepsinogen, right? Pepsinogen in your stomach, right? And then it's converted to pepsin, active form. Or you may have heard of fibrinogen, right? When you're making a blood clot. So all this gen is the ending of it, right? Is essentially it's a zymogen. It's inactive, but when this renin enzyme acts on this angiotensinogen and they combine, right? What do they make? I think Angela, you were saying, right? What do they make?
Angiotensin 1.
Angiotensin 1, right? So let me take a different color. So you are 100% correct, right? They make angiotensin 1, right? They make angiotensin 1. The moment renin, the enzyme, combines with angiotensinogen, right? And the distinction I want to make, angiotensinogen is inactive, right? But the moment renin acts on it, it makes angiotensin 1. Then, as angiotensin 1 passes through your lungs, right? There's a very special enzyme that's going to take this angiotensin 1 and is going to convert it into angiotensin 2, right? Can anyone tell me the name of this enzyme, right, that's going to convert angiotensin 1 to angiotensin 2?
Is it ACE?
ACE, right? What's ACE stands for? What does ACE stand for?
Angiotensin converting enzyme?
Yeah, ACE is angiotensin converting enzyme. So very good. ACE is going to convert angiotensin 1 to angiotensin 2. Now, I have a very, very important question, right? So in your lungs, as you guys know, right, as you come in, we have the trachea, right? Then it goes into, subdivides into your bronchi. We have the terminal bronchi. Eventually, it's going to lead to the alveoli, right? Where exactly in the lungs is angiotensin converting enzyme produced? You guys can take a guess. Where do you think? Right? We have
Is it in the capillary?
We have the alveoli. We have the bronchi.
I'm thinking
Right,
the
trachea.
bronchi.
Where is it?
Let's say the bronchi.
The bronchi, right? Anyone else? I heard that Ian said, what did Ian say?
Capillary.
Capillaries. So Ian says capillaries. So I think James said bronchi. Anywhere else?
I'm going to say capillaries of the alveoli.
Capillaries of the alveoli. So we got 2 for the capillaries. And let me ask you guys this. Why do you think it's made in the capillaries? They also say it's made in the capillaries.
Because that's where the exchange is happening.
Exchange of what?
From oxygen to
Was it gas exchange?
the gas exchange.
So
And it doesn't have to do something with like transportation?
Transportation. Who said that?
Mike Juan.
Yeah, correct, right? Mike Juan, you're correct. So those who said in the capillaries are correct, right? So it happens in the pulmonary capillaries. So ACE is made in the pulmonary capillaries, specifically in the endothelial cells of the pulmonary capillaries. So where is ACE made? So ACE is made in the endothelial cells of pulmonary capillaries. And the reason why this is made there is because we have this exchange, right? If you think about it, right, we have blood flow, right? The blood that's coming and it's flowing through here. The blood is what? The blood is carrying this angiotensin 1, right? It's the blood, right? The plasma that has now having the contents of renin combining with the angiotensinogen, making angiotensin 1, and now it's carried on, within the blood, right, through these endothelial cells in the pulmonary capillaries. And this is precisely, right, where this enzyme, right, let me draw this enzyme here, right, precisely where this enzyme is on these endothelial cells. And this is exactly where this ACE enzyme will convert, right, angiotensin 1 to this angiotensin 2, right? So now we finally made angiotensin 2, right? So angiotensin 2 is going to come out here, right? So it's in your circulation, right? Angiotensin 2. So what do you guys know about angiotensin 2? What does angiotensin 2 do?
It raises blood pressure.
It raises blood pressure. Okay, anything else? So Angel says, all right, angiotensin 2 is going to raise the blood pressure.
Vasoconstriction.
Vasoconstriction, right? So it's kind of similar, right? Vasoconstriction, increase the blood pressure. Anything else?
And also it's going
That's
to
like a
secrete-
sympathetic effect.
Is it like the body? Is it another way of the body's trying to keep homeostasis?
Homeostasis,
Might be
right?
wrong.
So you guys, all of you saying correct stuff, right?
It's also going to secrete aldosterone.
Oh no! Now Angel is, you're giving even more precise answers. Yeah, it's going to secrete the aldosterone. So let's go step by step, right? So first of all, you guys said 100%, right? So I'm going to come over here. I'm going to say angiotensin 2 response, right? So it's going to cause vasoconstriction. But it does not just vasoconstriction, it does a couple of things. It does venoconstriction, if you want to be precise. And it does arteriolar constriction. And you'll say, what's the difference? Right? So if it does venoconstriction, and I'm going to show you here, right? So it does venoconstriction. So look here, right? These are your veins, and majority of your blood, right? About 60% of your blood is found in the veins. It's found in the capacitance vessels. So what angiotensin 2 will do, there's receptors for angiotensin 2, right? As angiotensin 2 is going to come here, it's going to basically squeeze on these veins all over your body, right? So if I have more squeeze, right? Do you think I have more blood coming in here or less blood? So if I squeeze my capacitance vessels where most of the blood is found, right? So you think more blood is coming or less blood?
Less.
So think about it. I squeeze, right? I said about 60% of your blood is housed in your veins, in your capacitance vessels. And I squeeze here. So if I squeeze it, right, I'm going to push. Think of it like you have a big hose, and inside the hose there's water. And I come in and I squeeze on the hose. It will move the water forward, right? So more of it will come out on the end. Does that make sense?
Yeah, the pressure is going to be greater, but the blood coming in on the other side is going to be less.
Yeah, the blood is, but in this phase that is true, right? But in this phase when I constricted, right, I took the size of the vessel from a bigger size that they were, and I squeezing them. So whatever blood that was there, I'm still going to squeeze it. I'm still going to mobilize it. I'm still going to move it, right? If angiotensin 2 comes in here. So if I do this, right, if I do venoconstriction, I'm going to move that blood. And what is that going to do? It's going to increase my end-diastolic volume, right, in that phase. So if more end-diastolic volume is going to come here, I'm going to increase my preload. So if I increase my preload, I'm also going to increase my, right?
Cardiac output.
Cardiac output. So correct. So I'm going to increase my cardiac output, and this venoconstriction will essentially raise my systolic blood pressure. So increase the end-diastolic volume, increase the preload, increase cardiac output, increase my systolic blood pressure. So this is what venoconstriction will do. However, right, you guys also know, right, there is angiotensin II receptors on your arterioles. So if I vasoconstrict your arterioles, right, I'm going to increase what's known as what? Systemic vascular resistance, right? SVR. Sometimes in the book they will call it PVR, peripheral vascular resistance. So if I do the squeeze on it, right, I'm also going to increase the blood pressure. But which blood pressure am I going to increase when I increase the systemic vascular resistance?
Diastolic.
Diastolic, right? Very good. So I'm going to increase diastolic blood pressure. So as you see, right, let me go on this major diagram, right? So if I mobilize, right, my veins, I'm going to increase my systolic blood pressure. If I vasoconstrict my arterioles, I'm going to increase my diastolic blood pressure. And tell me this, in a setting of someone who got stabbed, right, and they're losing blood, is this good or bad that the body's doing this response?
Bad.
It's in the short term, bad in the long term.
So good. Science says good. So excellent, right? In the short term, it's good because this mechanism is going to maintain my blood pressure, right? Systolic, diastolic, but in the long term, it's bad. But we're going to get to that. Number two, right? Angel said, well, it's also going to release aldosterone. So let's look at it, right? So here we have the adrenal cortex, right? You guys remember from the other diagrams I showed you, right? Adrenal cortex is located above the kidneys, right? And you guys know it secreted the epinephrine. But here I want to say, right, when angiotensin II, right? So let me write this down here. When angiotensin II comes out, there's also receptors on the adrenal cortex, right? It's going to come here. Specifically, there's, 3 zones that are found there, right? So there's 3 zones in the adrenal cortex. Let me draw it like this: 1, 2, and 3. So this is, we're going to say this is 1 zone, this is 2nd zone, this is 3rd zone. When angiotensin II comes in on this 1st zone, this zone is called Zona Glomerulosa. And the Zona Glomerulosa is going to secrete aldosterone, right? So aldosterone from angiotensin II, right, is going to come into your circulation. So we'll get aldosterone. So this aldosterone is now in your circulation, right? It's found, right, now systemically, right? And now we got to see what this aldosterone will do. What does this aldosterone do? Who could tell me, right?
Doesn't it stimulate the sodium and water intake?
Ian, can you repeat that again? I think you were saying correctly, but I just want to make sure I hear it well.
It tells the renal tubules to keep the sodium and
Keep the sodium and what else?
Secrete potassium.
And water, right? So yeah. So let me show you what it does, right? So here we had the nephron, right? Here was the nephron, and in this, right, distal convoluted tubule, right? We also have what's known as principal cell. And what I'm going to do is I'm going to take like this section, right? And I'm going to draw it here, and I'm going to show you, right? So the function of aldosterone. So we're going to say this was this portion of the kidney, right? We're going to say this was where the urine is going to come out. And here we have something known as the principal cell, right? And what happens is we now, right, see this aldosterone that was stimulated by angiotensin II is going to come into the circulation, right? And eventually it's going to flow into your kidneys through the efferent arteriole. And finally, right, it goes here and it comes inside the cell, right? So we have aldosterone. So what this aldosterone does is as follows, right? Remember I was showing you all these channels? So inside your cells, right, there's obviously a nucleus, right? And aldosterone is going to act on the nucleus to produce more messenger RNA to make all these channels. So first thing that it will do is as follows, right? It's going to stimulate the cell to make more sodium-potassium pumps on the basolateral surface. So these are sodium, potassium, ATPases, and it's going to make more of them. Right? And remember, right, we said the role of this was to do what? It's going to kick out 3 sodium for every, right, and bring in 2 potassium. So it's going to bring in 2 potassium here, kick out 3 sodium. What else will aldosterone do? The other thing aldosterone does on this surface, right? This is the luminal surface, right? This is where your urine is made, right? On this luminal surface is going to start making these channels. So this is going to be your sodium channels. And it's also going to stimulate your cells to make more potassium channels on the luminal side. Right? So this is what the aldosterone does. On the principal cell, when the aldosterone comes inside, it's going to stimulate the nucleus to make more messenger RNAs, to make more proteins. What are these proteins? These proteins are these channels, sodium, potassium, ATPase, which is going to be forming on the basolateral side. It's also these sodium channels and these potassium channels. So think about this, right? This pump is pumping sodium out, right? So inside the cell, there's less amount of sodium. So any sodium that's now coming in here, right, it's going to go through these sodium channels. And the moment it goes through these sodium channels, these sodium potassium ATPases are going to want to kick out the sodium out. Make sense? At the same time, right, as this blood is flowing, right, it's going to bring in these potassium from the outside. And now, right, this potassium is going to flow inside. And we know, right, this was going into the urine. So the urine is being formed, right? And this goes into the urine and the collecting duct. But this, all of this that's pumping in here, this goes into interstitial space, like your medulla, your cortex, and it's being reabsorbed by the body. So what did this aldosterone do? This aldosterone is now grabbing from the blood that's coming here all the sodium that it had, right? And it's moving all the potassium out, right? And you guys know, right? With sodium, water follows. So the sodium is going into the interstitium. It's going to pull water with it. That's why we say aldosterone retains salt and water. But the other important factor you guys need to be in mind, right? It does what to the potassium?
Secretes it.
Yeah, so you're losing potassium, right? The way they would call it is caliuria, right? Caliuria meaning potassium found in the urine, right? So it's secreting potassium out. So the goal of aldosterone is to reabsorb salt and water and to secrete potassium out through this mechanism. And now if we come back to this diagram, right, and we already know what the principal cell will do, right? It's in the interstitium, it's reabsorbing salt and water. And if I reabsorb my salt and water, and the guy who was hemorrhaging blood, right, retention of salt and water, right, I retain salt plus H2O, this also is going to improve my blood pressure, right? So again, in the short term, this is great, right? The retention of salt and water is going to boost my blood pressure, right? And is going to conserve my, right, hemodynamic status. So far, so good, right? Any questions about these hormones so far, what we've done? Because now we're going to talk about some abnormal stuff. So anyone have any questions about any hormones, any enzymes so far?
Yeah, Nick.
Yeah.
So when the body's getting rid of the potassium,
Mm-hmm.
that would set off an arrhythmia.
Will it set off an arrhythmia? Yeah, it may. If you are at a level where you have hypokalemia, right? And I'll have a slide to that. Yes, it will eventually. Actually, let me go to it now. I will. So normal potassium level, right? Normally is about 3.5 to 5.0 millimolar, right? So normal. This is your normal ECG. So if you are, having sustained losses of potassium, right, you will see these flattened T waves, right, and prominent U waves. Yes, you could see this on the EKG. However, truly speaking, we are only taking, level of electrolytes through blood work. So you may have this on your EKGs and you may correlate with what's going on. But truly speaking, to really know the level of potassium in the blood, right, we have to check the blood work. But if you have sustained losses of potassium, yes, you will get to this level. And we're going to talk about, why do I bring this up, right? We're going to have some diuretics, which are, right, potassium wasting diuretics. And we want to know, right, what's going to happen to the person, right? So one of the signs and symptoms, especially on your diagnostics that you're going to see, right, you may see this flattening T waves, right, U waves development, and this is in the setting of hypokalemia. All right, so let me go back to the diagram that we had here, right? So this was that. Any other questions? Any other questions about anything so far? Or everything is clear? Everything is clear. Okay. So we talked about angiotensin II, right? With vasoconstriction, with all this. Now, imagine the following situation. I'm going to give you now, a situation where this is going to be abnormal, and we're going to see what's going to happen with it.